Hello, everyone. I have a great pleasure to talk with the esteemed professor of cancer medicine and medical oncology from the Imperial College in London. He's also editor-in-chief of the Onkologije journal and professor of translational research, if I got that correctly. Welcome and thank you very much for this opportunity to pick your brain a bit. I believe this will be very useful for the viewers. To start, would you like to add something about yourself and present yourself to the viewers from Serbia and tell us more maybe about your work during the COVID pandemic?
Sure. Hi, my name's Džastin, and thank you for that. As you know, it's been a very stressful time for everyone during the COVID pandemic. And at the beginning of the pandemic in January 2020, a group of colleagues and myself used artificial intelligence to ask two questions. Is there a safe drug already out there that can have an antiviral effect and was also an anti-cytokine at the same time? And we identified one, and I led all the international work with a fabulous team in 14 countries, over 50 people, multiple institutions that ended up resulting in the FDA approval of this drug within 10 months. And I wanted to describe that story to you. So it's not really a cancer story, but encompasses everything that we know is important in cancer, such as molecular and cellular biology, various screens, epidemiology, statistics, of course, and really working and collaborating with people around the world. But this time we just did it really, really quickly to great effect. And it was incredibly exciting. So I'd like to tell you the story of that particular journey.
Sure, I would like to hear that as well.
Are you okay if I give a little talk about this?
Of course.
So as mentioned, my name's Džastin. Although I'm a professor of oncology, as you know, during the COVID pandemic, many of our attentions have turned to other things. I'd like to talk the story. We talk about bench to bedside in oncology. I'd like to talk to you about the story here from the computer to FDA approval within 10 months. It was incredibly exciting. And here's a disclaimer, which includes the fact I have had consulting fees from Eli Lilly, who own the molecule. And what's remarkable is the number. I published a couple of pieces in the Lancet at the beginning of February. This slide is inaccurate now. These citations are now over 1,000. If you look at them, which for pieces over a year, a year ago is quite something. So I worked with a team at Benevolent AI to identify already approved drugs. So we knew they were safe with potential for use in the management of COVID-19. Now we know that SARS-CoV-2 uses a specific receptor, ACE2, to enter cells, but ACE2 in turn uses two kinases, AAK1 and GAK, to regulate endocytosis. And we basically asked at a very simple level, is there an existing drug out there using artificial intelligence that we can identify that has an anti-cytokine effect and an antiviral effect? And although we came up with some oncology drugs such as sunitinib, that wouldn't be safe in COVID. So we identified baricitinib. And what was interesting was that other JAK inhibitors such as tofacitinib or ruxolitinib were not identified by this algorithm. Now, in oncology that different drugs of the same class can have markedly different effects. Just think of Tarceva versus Iressa, for example, or in other aspects of medicine, think of Lipitor versus simvastatin. And it wasn't surprising that a drug that's already approved in rheumatoid arthritis could have anti-cytokine effects. That wasn't a surprise, and that's pretty obvious. But what was surprising to us and other people was that it could have antiviral effects. And when you look at the mechanism of action, it has this dual mechanism. Again, stopping viral entry and stopping the hyperinflammation. But this is all very well in theory off a computer, and you can say anything off a computer. What about the practice? Well, We did some laboratory work as well. Now, don't forget, this laboratory work was done last March and April, when it was not very easy anywhere to enter into laboratories. What we found was that in vitro, it inhibited inflammation mediated by lymphocytes, and in particular, decreased plasma interleukin-6. And we showed that at physiologic concentrations, it inhibited the kinases that are responsible for viral entry. And we also performed 3D liver organoids, little livers in dishes, and tried to infect them. And we saw baricitinib blocking this. And this is the sort of data we were collecting, where baricitinib affected the p-STAT signaling pathway during the dosing interval across subsets of lymphocytes and leukocytes. And as you know, interleukin-6 levels are elevated in COVID patients, and this decreased them. And we actually showed this in stored samples as well across different cohorts. And in fact, in a paper we published in the Journal of Allergy and Clinical Immunology, we looked using mass spectrometry at 185 different biomarkers related to the host immune response. And we found that all the inflammatory cytokines were reduced by baricitinib. And we thought maybe the reason this is more effective than the anti-IL-6 antibodies is it can reduce so many cytokines. What we saw with use of the anti-IL-6 antibodies is, although IL-6 decreased, other cytokines were increased, like in a feedback loop. I mentioned that baricitinib, and I'm going to go quickly here because this is probably a bit boring and technical, but I mentioned baricitinib binds to and antagonizes these 2 or 3 kinases involved in internalization of the virus, much more so than other compounds that were related to it. And also in liver organoids, we showed that baricitinib decreases the ability of the virus to get into cells. So we're moving across different in vitro models. So the summary from February to May 2020 was that it has a dual mechanism, inhibits the kinases, and it inhibits inflammatory signaling. And we validated this in different models. But really what we want to know is about people. Now, by this time, we'd published these sorts of papers in top journals like Science Advance. You can see the number of institutions and the size of the teams here. Huge numbers of people supporting the artificial intelligence predictions. But really what we wanted to see was more detailed effects and results in people. Well, in Spain, we started giving this to people with a median age of 81 years old. These are elderly people.
Mm-hmm.
And we saw, using propensity score matching, a dramatic decline in mortality. We did other work. We did RNA-seq of infected livers, again, organoid work. And what we found was that baricitinib, that the virus upregulates all the platelet-activated genes, all the clotting genes, explaining why the virus can cause clots. But baricitinib again ameliorated that. And we performed super resolution microscopy. These are images where the virus nuclear capsid protein is stained and it goes into cells, and with baricitinib, you see no cellular entry. So that was incredibly exciting, but it depended on the cell line we used, it depended on the experiments, it depended on what we stained for. And it was complex, hard lab work, so we performed a massive international clinical study. This was published in the New England Journal of Medicine. This is more than 1,000 people. And patients were randomized to remdesivir plus baricitinib versus baricitinib alone. This is the ACT-2 trial. The baseline characteristics were similar. And what we found was that there was a benefit in every single subgroup to giving baricitinib along with standard of care. And what was surprising to us was that the benefits were more pronounced in the people just about to go onto ITU. This is ordinal scale 5 and 6, very oxygen dependent, very sick, but not yet requiring ventilation. So it seemed that although steroids are very effective, steroids are useful only when you're on ITU. This seemed a very good drug to stop people getting to intensive care. We looked at all these secondary outcomes, and you can see in this forest plot, all the shift to the right, that it doesn't matter what subgroup you're dealing with, young, old, it seems helpful. In November, based on our data, the FDA approved baricitinib for use in COVID. And along with the vaccines, we seem to have really made a big difference in the pandemic. There's more clinical trials to report, but to me, this was a story of international collaboration, record time from the computer to the bench to the bedside, and really very, very exciting to work with such amazing teams and cut down walls and work really, really quickly. Thank you very much.
Yes, thank
Questions?
you. This is very big collaboration and really exciting results that
Right.
you have indeed. What would be like the next step for this now? I mean, it's a great example of translational medicine, right? From research to clinics in such a short notice. But what would be the next step? Do you see it being in the clinics as fast as we need it, or is it something that we still have to make a lot of research? Because usually that's the case, right? I mean, now it's exceptional circumstances, but then
I mean, look, we've seen drugs like baricitinib go from computer to FDA approval in 10 months. We've seen 30,000, 45,000 patient phase 3 vaccine trials be done, you know, in a year. To me, medicine's changing. Collaboration can really make all the difference, and everything's going to change going forwards. The future of drug development, though, on oncology has lessons with this, because the future of oncology is going to be a drug for a smaller and smaller subgroup of patients.
And personalized medicine in general.
I'm not saying that. Obviously, there's personalized medicine, which is treating the right patient at the right time with the right drug for the right tumor. Of course, that's personalized medicine. But what I'm saying is that future drugs will treat very few people. But in the people for whom it's suitable, the effects will be much larger. So just think of the, you know, ALK inhibitors or the NTRK inhibitors. You know, there's not many patients that are suitable, but in those who are suitable, it's really, really exciting.
Yeah, true. And do you expect any like interactions with the host genetics, so the genetics of the people itself? Because now what we there is also this huge consortium that I'm also involved, but many different studies. The host genetics initiative for the COVID, where we found in a large scale the US so far that there are some especially inflammatory pathways that are involved in the severity of the, you know, the clinical presentation of people, because we always talk about how different people end up in the hospital and the ICU, and then somebody doesn't even have any symptoms, and how is it possible? It's not very clear so far, but at least we have some input from genetics now. I'm not sure if you are aware of those results, but do you expect any interactions of these medications with the genetics of the host?
Right.
Or in different strains of the virus, for that matter. So genetics of the virus as well.
It's interesting that, I mean, the host genetic story with everything from TLR9 mutations to anti-interferon antibodies to different interferon response genes is fascinating, but it doesn't fully explain, as you said, why some people are fine and asymptomatic and other people are on intensive care. It does in some cases, but if you look at the anti-interferon antibody study with all the papers published in Science, it's a small minority of patients, as you know. What's interesting about baricitinib is the only antiviral that targets host genes, and it targets host kinases. And just like in oncology, some people absolutely live a long time with the cancer, and other people it goes right through them. Host genetics is going to be an incredibly important part of a jigsaw going forwards. It's not just going to be about the tumor and the drug, it's also going to be about host genetics. But if the road of host genetics is, you know, a mile long, we're about 20 yards into it, is my view.
Yeah. Well, I think the story about the medicine and all the nice research you showed would be very useful to our colleagues first to learn about it. But I would like to ask you also some questions that we had from people that are asking, patients, and in our organization we usually answer the questions from a medical point of view to people in a hope to promote vaccination and to promote compliance with the epidemiological measures and so on. So we have a lot of questions about the oncology and from the patients, oncology patients. So just to start with about the translational medicine, what I wanted to ask you is, so we have this huge infodemic, right? And you are also editor-in-chief of the Oncogene. So from that point of view as well, you can answer. We have the basically hijacking of all the journals by this COVID topic. We have publishing in preprint a lot. We have, you know, like the global infodemic. And how can people know what to trust and who to listen? You know, they want to be well informed, but they don't know where to find the proper scientific information that they can understand. So what would you suggest to them from that point of view?
I think all the points you raised, especially with social media now, propagating information, is so true. Let's say you take something like a big subject. Let's say you take something like, do the vaccines work against variants? Let's say you take a big subject like that, where there's literally hundreds of studies as preprints, although Nature Medicine has just published 3 full papers. And obviously papers are better than preprints because they're peer reviewed, but they're slower, right?
Yeah.
So let's say we take those. Well, if you read them and study them, what you'll see is they probably do work against variants, but a bit less well, okay? Unfortunately, the reality is you have to make a jigsaw. There's many, many different pieces of the jigsaw. It takes a long time to build a jigsaw, and you always want different studies validating each other. But the basic message you get when you go through them is it's a complicated answer. They do work. It depends on the vaccine and it depends on the variant, but slightly less well in general. You can build up a picture in your mind. You can actually build up a jigsaw. And so what I would say to people is, obviously peer-reviewed published studies are more reliable. Social media can be horrible and unreliable, but there are reliable sources out there, and a lot is, you know, at least some sources have been filtered, like peer-reviewed journals. But it's a difficult one. It is, there's no question that the issues you raise are just incredibly important.
And the consequence is probably less compliance with everything and much difficult situation that we are in when people are so confused and trust no one and try to Google, try to educate themselves, think they are bigger doctors from doctors and so on, you know.
I mean, what's amazing is I talk to intelligent people. So I've talked about the risk of cerebral venous thrombosis with, say, the AstraZeneca or Johnson & Johnson vaccines. And I've said to people, well, it looks like the risk is probably about 1 in 200,000 or whatever number I've said. And they've turned to me and said, well, that's quite a lot then. I think people don't understand risk with big numbers.
Yeah.
And there's not a lot anyone can do about that at the end of the day. So we know, for example, let's say you take vaccine refusal or vaccine hesitancy. One of the worst things you can do is just show people tons of data, because, you know, but if you show them that their friend has had it and a famous person's had it and everyone else is having it, and if they want to lead a normal life, they need to have it, that's different. But one thing people don't respond well to is just being told tons of data, because smokers know it can cause lung cancer, but they still smoke, right? So, so I'm not very good at psychology of all this. You know, you mentioned the infodemic, which the WHO warned about over a year ago. There's horrible stuff all over social media. We've now got YouTube and Facebook taking down a lot of disinformation posts, but it's a difficult.
Still a long way to go. Yeah.
Still a long way to go.
Okay, and if you want to somehow, from your point of view, describe the last year in London and the UK, how kind of satisfied are you with the strategy that the country took, or the compliance measures and so on?
On the one hand, the UK has had one of the worst death rates in the world. And it's, you know, we have these care homes where it's just been catastrophic. You know, we've got 150,000 deaths and so on. But on the other hand, we've done amazingly with the vaccine to get us out of it. Because we bought at risk, we bought early. I think overall the UK has done well. That's my view. Interestingly, with the vaccine with the EU, clearly with 27 people around the table struggled to make a decision.
And for Serbia in particular, we have 4 different vaccines largely available.
But that's amazing. I remember I spoke to your prime minister at the start. I introduced her to Moderna at the start of the pandemic. But these, you know, and people talk about the cost of these vaccines, but at the end of the day, it's just a few cups of coffee per vaccine.
True.
You know.
But comparing different vaccines is something that people like to do here as well a lot. And also the country actually gave a choice to people that you can choose which vaccine do you want. And well, that's where we come to the problem.
We didn't give a choice in the UK.
Exactly. This is where we get to the problem, because what knowledge people have to be, you know, how to say, well informed, or to get an informed decision on which vaccine do you want to choose. How well do they understand the differences between the vaccines? It's what amazed me, you know, that's how it's done. And then what you have the nationality of the vaccine actually that people are picking based on, you know.
I mean, what I would say in terms of data is I would say that both Chile and the Seychelles had remarkable vaccine rollouts in that they vaccinated a lot of their population very, very rapidly. But because they used a lot of the China vaccine, they've both suffered with second waves. Now, in February of this year, I published a piece called "Where is the phase 3 Chinese vaccine data?" Okay, that was in February of this year. We've still not seen it anywhere.
But let's go on with oncology patients is what I want to ask you about. So if we talk about the patients and COVID, so getting the disease, we receive a lot of questions, and I think it's a valid concern as well. So we do know that they are at higher risk of more severe outcomes, and like if you are comparing with their healthy peers. But what is your experience? Is there a predictive marker in that sense that would tell us in advance if somebody ends up in the ICU or worse, or have a mild clinical presentation, you know, within the cancer patient? What can they expect in that sense? Because they are very afraid now.
So I published a paper, I was senior author on in Journal of the National Cancer Institute, which was a meta-analysis of all the published studies. And what we saw was that the mortality from COVID and cancer was up to about 30%, with people with hematologic malignancies and lung cancer at risk. What I would say is that everyone with cancer needs a vaccine. They need a vaccine soon. But unfortunately, there seems to be a specific quirk with some of the hematologic malignancies like myeloma or CLL, where the vaccines seem to work less well. Obviously, you can speculate on the reasons why, in terms of the immune system, blah, blah, blah. But I would say that cancer patients should be vaccinated as soon as possible, but they should be careful. Simple as that.
That's the next question. Like, would you suggest a timeline here? Because that's we get the question. In my therapy in the first dose, second, when can I vaccinate in time wise? Like, should I wait to finish all the therapy, or should I do it in between the doses, or the time, should they recover a bit from the therapy and then take it? When is the best possible time to, and I would say the faster the better, but like, we want to hear your opinion on this, on the timeline of getting the vaccine.
I understand, I heard the question. They should have the vaccine as soon as possible. It doesn't matter what treatment they're on. They shouldn't wait to finish chemotherapy. If the vaccine's available, have it. And I would recommend, if possible, any of the Western vaccines. I'm not sure I trust Sputnik 5 or the Chinese vaccines. We've seen published data for Sputnik 5 at least, but I'm worried about what happened in Chile and the Seychelles with regards to the Chinese vaccines, and I would trust any of Johnson & Johnson, AstraZeneca, Pfizer or Moderna completely. And one dose is better than nothing. Obviously Johnson & Johnson is just one dose, but one dose is better than nothing.
So you would say that the chemotherapy or radiotherapy or having a cancer or any other procedure, therapeutic, is not a contraindication for getting the vaccine?
Absolutely not.
Yeah. Okay. Do you have a preference between, not a preference, but like how people react if they are on chemotherapy or if they are on radiotherapy? Is there a difference on how do they react on having COVID, so getting sick with COVID? And also, of course, vaccination, but do you see any differences there? Is there any consensus?
No major differences.
And let's see what other questions that people asked. We answered about the therapy cycle, so it does not matter, and the timeline. And what about the surgical operation? So if you have scheduled the operation, and what is the state of your immune system?
I'm going to say exactly the same. Have the vaccine as rapidly as possible.
Okay.
Sorry to be boring.
No, but that's something people should really hear, I think. Right? So they should be reassured.
And what the vaccine is much better than natural infection, because natural infection stuns the immune system as well.
Yeah. It's probably not as long lasting as getting the vaccine.
Right. And what we see in the NHS Siren study published in the Lancet was that after natural infection, reinfection occurs with a median time of 5.3 months.
Okay. And then do you have the same information for after the vaccine? Yeah, the vaccines are not long enough there.
Right, exactly right. I mean, the vaccines aren't 100%, so you do get reinfections afterwards, but
yeah, but with a more milder symptoms as well.
Right.
And if we are talking about the palliative medicine and end of life care, does it make sense for those people to vaccinate?
I think so. It depends how long. It depends how long someone has to live, doesn't it? But I'd prefer people not to die of COVID. personally. And the vaccines, even if they don't work fully, they seem to be good at protecting from hospitalization.
Because what we want to do is to improve their quality of life, right, as much as possible. This is all we can do at that point. But can vaccine, can their body accept the vaccine in that sense and develop the immune response we want? Probably, I would say less than beneficial, or is it still beneficial for them to vaccinate? This was my thinking or a question.
It's even if they don't work fully, they seem very, very good at protecting from hospitalization, which is really what you want them to do. Every single phase 3 vaccine trial showed that we've seen published has shown no hospitalization. I don't know about Sputnik 5, but has shown no hospitalizations or deaths in the vaccine arm. This is the 4 I'm talking about: AstraZeneca, Moderna, Johnson & Johnson, and Pfizer, obviously. And we're waiting to hear the Novavax further data. The Novavax vaccine looks a decent product if they can make it adequately.
And many people are questioning the new technology, in a sense, about the mRNA vaccine. How would you reassure them? This is new, this is made quickly, that's all true, but it's based on technology that's developing for quite some time. So how would you reassure them?
So the technology, as you say, derived from next generation sequencing, has been around a long time. The great thing is about the platforms is they're very adaptable to variants. You can make things at scale, and the data speak for itself. You've got 94, 95% efficacy for Moderna, Pfizer. It looks spectacular. And because it doesn't integrate into the host genome, I think there are no safety issues other than, local reactions that occur when you give people the vaccine. And
against the new strains of virus or possible future new strains that are more...
different companies have different approaches. Pfizer wants a 3rd shot of its regular sequence. Moderna are using variant sequences. There's probably going to be Novavax the other day published a combination of flu vaccine and COVID vaccine in hamsters. We're going to be able to use lots and lots of different combinations going forwards. And I'm very confident about the world, provided everyone is vaccinated. And always you're going to have a lot of people who are hesitant or refusing it. You're going to have the crazy anti-vaxxers saying all sorts of things about 5G and Microsoft and whatever. And the reality is vaccines are our way out, because although I worked on baricitinib, which has been a great treatment and FDA approved, the treatments for this virus are not amazing. They decrease hospitalization time and things like that. Baricitinib actually has the greatest mortality reduction with a hazard ratio of 0.65 from the COV barrier study, which is much greater than the steroids or remdesivir. But really our way out of the pandemic is not treatments for the virus once you've got it, or for pneumonia. It's prevention with vaccines. That's really the way out.
Yeah, and you would suggest the usage of this medication for those, as I understood from your presentation, from those people who are about to kind of have to go to the ICU or
correct.
There,
absolutely,
right?
Absolutely.
But would it make sense also to give it regularly?
Well, we're going to see people are. I wouldn't use treatments like baricitinib regularly. I mean, it's a regular treatment for adults with rheumatoid arthritis, but I wouldn't use it to prevent. And the prevention story with drugs, I mean, certainly hydroxychloroquine was harmful, but the prevention story with drugs is a tricky one, because you need to do very big studies for a very long time with huge number of people and events, and it's difficult to pull that off. We've looked at prevention studies with things like tamoxifen, haven't we, in oncology, or even exemestane, and it takes a long time, and even if the data is positive, people are not that keen to do that.
Yeah, and we have a lot of talk about the ivermectin, the medication that is for animals primarily, but many people are using it now in Serbia. And although it's not kind of very proved to work, what is your take on it?
In the Journal of the American Medical Association, we have an ivermectin randomized trial, mainly performed in Colombia, actually, on time to resolution of symptoms. Small study, but no differences. On the other hand, you do see some spectacular results talked about in single-arm observational series. And it does seem a safe medicine. It's been given to millions of people with river blindness, and it's been used as a veterinary medicine, as you know, for decades. And the discovery of ivermectin led to a Nobel Prize, a few years ago. It's a great drug, but I'm not convinced about its activity in COVID because I've not seen any randomized data despite amazing anecdotes. The problem is, you've got to understand this is a virus that most people get better from anyway.
Yeah.
So, yeah.
One more question for you, and then we can finish this lovely talk. About the kids, oncology patients, do we have any differences in treatment? Are there any differences in the reaction to COVID, to vaccines? What should we know about the kids and that have cancers and leukemias and other blood cancers?
I mean, a few things. As you know, last week, the FDA approved the Pfizer vaccine for 12 to 15-year-olds. So does the CDC endorsed that. We're going to see results from Moderna's results are positive. We're going to see results from younger and younger children. And of course, on the whole, everyone knows that apart from the multi-system inflammatory syndrome, which is very rare, the Kawasaki-like disease is very rare for a child to become sick. Obviously, a child with cancer can become sick, but people have mainly been concerned about transmission events from children, cancers and immunocompromised, the virus and immunocompromised hosts mutating and infecting others. I think the direction of travel is that we're going to be vaccinating sicker children, including children with cancer.
Yeah. Okay. Great. Thank you very much for your time.
Thank you. Pleasure.
I hate to take more of your time, but
not at
all. We appreciate greatly you.
I appreciated the opportunity to talk to you all.
Yeah, thank you very much.
Thank you.
And I hope to keep in touch.
You too. Thank you.
Thank you.
Bye.
Bye.